All right, it is 9 o'clock. We're going to go ahead and get started. So, welcome to Air St. Luke's Presents. Today we've got Dr. Ellsworth. She is a ER physician in Magic Valley and also a physician of toxicology. I'm really excited to hear her lecture today. It's going to be about sedation and toxicology patients. And with that, I'll turn it over to you, Dr. Ellsworth.
Okay, well, this is a new form for me. Usually when I'm lecturing, it's live, so there's some interaction. I'm hoping that that will be the case today. Otherwise, this is going to be really boring. I am sure medical toxicology and pharmacokinetics is like everyone's favorite topic. It is actually one of mine. And let me start this with, there is going to be some opinions and statements from me. I think you can get varied responses. One of the most respected medical toxicologists that I have ever had the privilege of working with has different opinions about how to manage certain things compared to me. He is adamantly against ketamine. I do think that there is a role for ketamine, and you'll see that later on. And I don't think it's a one size fits all. And so I cannot fill, I don't know how long they wanted me to talk, but 60 minutes of a lecture on sedatives and toxicology patients. There's just not that much literature. When you look at evidence-based medicine in emergency medicine, in pre-hospital medicine, it differs from toxicology. We don't have a lot of randomized controlled clinical trials because these are very vulnerable patient populations. So it's really hard to get IRB approval. It's hard to get the numbers needed to really make hard, concrete statements. And so I think one of the things that I hope you take home from this is being able to identify toxidromes so that you can target your sedation to the specific physiologic effects that you're observing. So we can go to the next slide. For anyone who works with Magic Valley paramedics, I apologize because they've heard some of this before, but the history is essential. Like, the dose makes the poison in toxicology. If you have subtoxic doses, then this whole conversation is mute, right? But that is actually a picture of Carson Harris. He was probably one of the best ER docs I ever had the privilege of working with, and he was my fellowship director. And he was so laid back. It didn't matter what you presented to him. It was always, he never said it was a bad idea or no. It was always, well, you could do that, but. And I think it taught me a lot about thinking outside the box and knowing that there's just, again, not one size fits all. When I am getting reports, I like a tox matters. So if you just remember matters, you can tell me the medication. Ideally, if you have pill bottles, please bring them. It used to be Tylenol was a pretty easy overdose. Now we have Tylenol arthritis, which is actually an extended release formulation, and it actually changes how we manage acute overdose in the ED. A single Tylenol level is not adequate. It's amazing how many patients think that they may be overdosed on ibuprofen, but instead it's Tylenol, it's aspirin. And so bringing bottles, if you have them, is really helpful. It also enables me to differentiate whether it's an immediate release formulation, if it's a sustained release, which would change the time that I observe these patients. So medication, the amount taken, and sometimes we're deducing, right? Not everyone counts. In fact, most patients don't count out how many pills they took. And our overdose patients are historically unreliable. But lots of times if you have a bottle that was filled yesterday and the right clinical scenario, you can do a worst case scenario in terms of amount ingested. Time taken, therapies tried. So what did you guys do during transport that may help me? Emesis, was there vomit on scene and did it contain pill fragments? Because that's a form of GI decontamination. It's just, it was done by the patient spontaneously and not induced by anything. The reason we tend to observe more significant toxicity with patients who are self-harming as opposed to patients, that are 4 years old and exploring their environment and just got into pills. That being said, obviously there are single pill ingestions in pediatric population that can be life-threatening, but certainly the dose tends to be higher and more significant in patients who are self-harming. And then what signs and symptoms are you observing? Next slide. So identifying toxidromes is essential because that really, again, tailors our treatment. And vital signs are vital. So if you can get a full set of vital signs, that's going to be really helpful. Does anyone want to volunteer and say, like, what inherently happens with a patient who's hypertensive to their heart rate if you take away toxicologic factors and in a patient who's otherwise healthy? The Cushing reflex. Am I just going to talk to myself? Okay. So
it becomes slow.
Okay, very good. Thank you. So the Cushing reflex, right? So you have elevated intracranial pressures, you get autoregulation, the body drives up your blood pressure and your heart rate goes down. So I always tell folks, if you see heart rate and blood pressure moving in the same direction, you need to think toxicology, right? So Idaho, I feel like we see lots of methamphetamine patients, right? They're tachycardic, they're tachypnic, they're hypertensive. That's a good example. What happens when you have a beta blocker or calcium channel blocker overdose? You see both a decrease in the heart rate and the blood pressure. Those things physiologically should not move in the same direction. Pupils, that can clue us in, right? Whether it's an opioid toxidrome, whether it's someone who's anticholinergic. I wrote skin there because are they wet or dry? That is like the key differentiation between someone presenting with serotonin syndrome and someone presenting with anticholinergic toxicity. Mental status, are they alert? Are they mute? Are they hallucinating? Muscle tone can be really helpful when we're assessing for like neuroleptic malignant syndrome, and then clonus for serotonin syndrome. Next slide. So Carson Harris was like passionate about cocaine toxicity. So I trained in St. Paul and Minneapolis, and we didn't see really meth users. We were a regional burn center. So when they would have explosions in meth labs from Iowa or North or South Dakota, those patients would get flown to us. But our regular patient population, they were classy. They liked cocaine. And so he was always in the back of my mind whenever I'm seeing someone with a stimulant intoxication. I think benzos, and more benzos. And I give big doses, like 2 to 4 milligrams of IV Ativan and back it up. And we'll talk later on about how maybe other benzodiazepines actually might be better options. But in general, you're not going to find a toxicologist who's going to fault you for using benzos and large doses of benzos. So the sympathomimetic toxidrome, everyone sees this. If you go, work a week in the ER in St. Luke's Magic Valley, you're going to see at least 4 or 5 patients who present with this, right? They've got large pupils, they're agitated, they have tachyarrhythmias, sometimes that's signed as tachycardia. They may be complaining of chest pain, they're hypertensive, they're hyperthermic, they can have seizures, they're diaphoretic. So I think that's a pretty easy one for most of us to recognize and identify. The next slide shows anticholinergic toxicity, which is actually probably my favorite. Like if I'm stranded on an island and I have 2 drugs, I choose the antidote physostigmine, which is used to treat anticholinergic toxicity, and then droperidol. I am a huge droperidol fan. I've used a lot of them in my career, and so both of those drugs, just have a special place in my heart, I guess you could say. So anticholinergic toxicity, does anyone know what like the prototypical drug is associated with this?
Benadryl.
Okay, I heard someone, Benadryl, very good, diphenhydramine. So if you see someone who's sick with an anticholinergic toxidrome, I think it really sticks in your brain. So they tend to be hot and dry. Lots of times they'll be mute. They're hallucinating. So you'll see them like picking at the air if they're toxic enough. I don't listen to bowel sounds. So if you do, kudos to you, but you'll have diminished or absent bowel sounds. They can be tachycardic. With severe Benadryl overdoses, it can mimic a VTAC because you can get QRS widening. I have some EKGs in a file that are pretty impressive. You give sodium bicarb and that narrows it right up. They can be red as a beet. They'll have dilated pupils. And if you correctly identify this, you can give physostigmine and it'll just take the symptoms away. It's certainly not of any mortality benefit or curative, but it is diagnostically helpful. The next one is a cholinergic toxidrome. I thought when I moved to Idaho to practice, I'd maybe see more of this. The prototypical drugs that cause this, right, or organophosphates that are used in agriculture, and then nerve agents. So I think all in all in my career, I've had one, and it was actually when I was still doing my fellowship. And so these folks are just wet, right? So they're sweaty, they're tearing, they're vomiting, they have diarrhea, they have bronchorrhea, lots of salivation. And then the next one should be easy for all of you to identify, right? An opioid toxidrome. So comatose, pinpoint pupils, respiratory depression, hypotension, hypothermia, hyporeflexia. I feel like everyone here is really good at identifying an opioid toxidrome. I guess a little pearl, and I think obviously if you're intubating, don't give Narcan. Probably 2 weeks ago, I was seeing a patient who came in with obtundation with one of our PAs, and she was on multiple CNS depressant medications, including methadone. And I gave her 0.4, of Narcan, and I think that poor nurse deserved hazard pay. So we then followed that up with 3 milligrams of IV Dilaudid and lots of Versed. But at least we had an answer as to why she was confused, right? So I always tell folks, if you manage the airway, once that tube's in, they don't get Narcan. We just allow their body to metabolize the opioid and move on. Next slide is serotonin syndrome, which sometimes is really challenging to differentiate from anticholinergic toxicity, but again, the skin findings. So serotonin syndrome patients are wet, anticholinergic patients are dry. There's all of these criteria to help you identify serotonin syndrome. So Hunter, Sternbeck, I don't use either of those. I use basically 3 parameters. Do they have altered mental status? Do they have autonomic instability? So fast heart rate, slow heart rate, high blood pressure, low blood pressure, and then neuromuscular findings. So whether that's ocular nystagmus or clonus. And if you get all 3 of those in the setting of drugs that can cause serotonin syndrome, that's how I make that diagnosis. I will say, and I don't think this is necessarily at least well known among the hospitalists that I consult on, but is there a narcotic that should be avoided in patients with serotonin syndrome? The answer is yes, but do you know what it is? Okay, I'm going to take the silence as no one knows. Okay, fentanyl.
Morphine. I'm going to go with morphine.
It's fentanyl. And there's actually case reports of patients getting therapeutic doses of fentanyl postoperatively, and they're on an SSRI, and it precipitates serotonin syndrome. And I only say that because I feel like pre-hospital medicine providers are way better than ER doctors at starting intubated patients on analgesic medication, like eons ahead of us. But I also feel like fentanyl drips are the narcotic of choice. And if I have a patient with serotonin syndrome, that is absolutely contraindicated. So something to keep in the back of your head when you're taking care of these patients. The next slide is sedatives and hypnotics. This would be like your GHB, your alcohol, benzodiazepines, stuff that you guys are really good at correctly identifying. So any questions so far? Okay, it's going that good. We'll move on.
Actually, okay. I do. I have a question.
Okay.
Sorry, it always takes a second to get off of mute and then actually have your question. So if fentanyl's not the preferred drug, are there other opioids in identified SSRI patients that you're targeting instead of fentanyl, so replacement for fentanyl.
Yeah, you can use morphine. Don't use Demerol, which no one's using anymore. Like they shouldn't have been using 15 years ago. But Demerol is highly serotonergic, as is fentanyl.
So Dilaudid would be okay too, right, Heather?
You can use Dilaudid.
Dr. Ellsworth, we got a couple of questions in the chat. If you could expand, both of them I think are similar. Expand on why not to use fentanyl. Like, what does it exactly do with that serotonin issue?
Sure. So serotonin syndrome is due to serotonin excess, and there's serotonergic drugs. And I think lots of times we're good if we think, oh, an SSRI, right? Prozac, fluoxetine, even SNRIs. Lithium is serotonergic, Zofran is serotonergic, fentanyl is serotonergic. So it increases the concentration of serotonin in the CNS. Your whole goal with serotonin syndrome is decreasing serotonin in the CNS. And so you should absolutely not be using those medications. Does that make sense? And you just have to know. I mean, unfortunately, there's no way that you're going to be able to commit to memory other than memorizing them, what drugs are serotonergic, or looking them up or having like a handy reference. But I think that's one of the big things that I've seen when I'm consulting on patients in the ICU. And granted, I would say that is a minority of serotonin syndrome patients that end up in the ICU, either intubated or hyperthermic or critically ill. For the most part, it tends to be more mild, but there are those severe patients, and I go over and I have to go through their drug list, and I'm continuously like stopping medications like Zofran and fentanyl. And I just say that because I know you guys have limited options. I think MVP now carries fentanyl and Dilaudid. Is that correct, Bertus?
Yeah.
And so, if those are your options, do not give fentanyl. And so this is, again, why being able to identify toxidromes is so important, not only for treatment, but sedation, because you want to choose the appropriate medication and you don't want to make it worse.
Right. And I'll add that the only reason I know about the fentanyl situation is because Heather taught me that. So it's one of those things where, yeah, it can slip through the cracks. And I think if you don't know, it's obviously understandable. But if you clearly have a serotonin patient, we really need to be sure that we're not doing that if we can avoid it.
And I get it. I have a lot more resources. This is obviously something that I spent 2 years of my life doing. But I do think we want to do a good job taking care of patients, and we can do everything right, and we can still have challenging scenarios. I have a very good friend who went in for routine surgery, got a therapeutic dose of fentanyl, and then ended up at the University of Utah, right? And again, no one did anything wrong. It's just unfortunately sometimes that is what we observe. And so again, if you can identify, or if this patient just overdosed on their citalopram, well, don't give fentanyl, please. I can't see the chat. So are there any other?
That was all in the chat. Oh, go ahead, Shandy.
Great.
Sorry.
I think you said it, but just to reiterate, so if you're choosing like an anti-nausea med, not Zofran, pick droperidol.
Yeah, in that one. And like droperidol is like good for all the LG, right? Like we'll talk about it. It has its own inherent issues, but I am a huge fan. But yes. Probably the only time that you don't want to be giving droperidol, right, is if a patient has NMS, which is neuroleptic malignant syndrome, because again, that tends to be related to antipsychotics. And later on in the slides, droperidol, Haldol, they are typical first generation antipsychotics. So that would not be appropriate. What do you carry for antiemetics, Bertus? Zofran, droperidol?
Yep.
Okay.
Zofran and droperidol. Yep.
Okay.
Heather, I do have a question for you.
Okay.
So this is Alan Bean. We had
Hi.
a discussion last week about about not using droperidol initially in our doses at greater than 0.625.
Yeah.
I disagree. I think we could go to 1.25 for our initial antiemetic, but we were
So
worried about some side effects. What's your thoughts on that?
I'm with you. So honestly, it was when I moved here, we could not give or use droperidol at St. Luke's. And so I had to go to P&T and bring all this information. But there's actually a great position statement from the American Academy of Emergency Medicine physicians that say we do not need to do any special monitoring, including an EKG for doses up to 2.5 milligrams. So for those of you who are not familiar, the reason that droperidol got a bad rap was this black box warning for QTC, interval prolongation, and risk of torsades. I am with you, Alan. I don't give 0.625. I give 1.25. And I give bigger doses. I do 10 IM for agitation. And that I do believe you should monitor more just because then it shows that you're aware of what the potential risks are, not because I've ever had an issue. I've seen, torsades actively with fluoroquinolone infusions. I have given, I'm guessing, thousands of doses at this point of droperidol between my training and what I use now, and I've never had a bad instance. And the patient population that I learned in at Hennepin County, they had what was affectionately dubbed the drunk tank. So we would have all of these chronic alcoholics that would come in, and they had their own special room in the ER that all the interns got stuck taking care of. And then we would release them into the world the next day, and they'd come back, and you knew most of them. But if they got agitated or aggressive, they were giving those patients 10 milligrams back to back to back. If you want to talk about a patient who's high risk for, electrolyte abnormalities and QT prolongation at baseline, it's them. So I'm with you. I think 1.25 milligrams in an adult is where we should be starting.
Heather, one of the things we were concerned about a little bit, we do use droperidol, and we're liberalizing our dosing definitely for agitated delirium, where we're allowed 2.5 to 5. Just that akathisia problem that people get, when we're in the back of the ambulance, some people get real freaked out, or, so that was one of our thoughts too, is could you do 2 doses of a smaller to get to that? Or is there a huge difference between the 0.625 and the 1.25 in terms of akathisia and those kind of unpleasant extrapyramidal side effects?
So here's the take. I just never give 0.625. So I see akathisia probably every shift, right? Because I use it a lot for my migraine patients. And it's not life-threatening, but like you said, when you're in a confined space with a patient that's crawling out of their skin, that can be problematic. I would have to look at the data. I can't tell you off the top of my head, and I don't want to mislead whether or not there's an inherent difference. I will tell you on patients who can't take droperidol because of akathisia, I'm using olanzapine IV, which is a second generation antipsychotic with few, and I've had no one get akathisia. And I use 2.5 or 5 IV, which is off label because it's only approved for IM use, but so is Haldol, right? It's never been approved for IV use. So those are the
it's just that.
But I just don't do 0.625. That's me.
Yeah. Okay. Yeah, no, that's helpful. That's just one of our considerations we had, is we always have those people that kind of get the willies and go running out of there. So we're like, hey, try this lower dose first and then go for the second. But there may not be a huge difference there. If they're going to get it, they're going to get it probably at a small dose. So that's just one of the thoughts we had. We're wondering how to go, and there may not be good guidance on it.
No, but in terms of effects, you have good support for the larger dose. Like I said, AAEM has a position statement, which I think is super beneficial. That's doses up to 2.5 are very, very safe and don't require any monitoring, and even doses up to 10 milligrams for, now what are we calling hyperactive delirium with agitation, right? I guess excited delirium is falling out of favor in most societal circles. So it's very helpful in terms of saying it's a safe drug when used appropriately, and even at those higher doses for delirious patients. Okay. And I can see what I can find. I don't know that off the top of my head, but I'll look into it for you so that you can have some maybe guidance if there's data to support either dose. Next slide. So quetiapine overdose, Seroquel is obviously this medication. Quetiapine overdoses are fairly common. Big things that we see are CNS depression, sinus tachycardia, hypotension, and anticholinergic toxicity. There is evidence. I've had quetiapine overdose patients who are basically comatose. We give physostigmine to, and they wake up. So there's good evidence to use that. You obviously won't be doing that in the pre-hospital setting. You'll be bringing them in and supporting them through the initial toxicity. But this is sort of one of the cases that they said some of this, questions regarding sedation in the tox patient came out of. So next slide. 34-year-old female ingests 5,000 milligrams of immediate release quetiapine after a verbal disagreement with her boyfriend. She was found unresponsive in her bedroom 90 minutes after a goodbye Facebook post. So quetiapine is a second generation atypical antipsychotic. So next slide. And one of the things that I think is sort of my pet peeve as a toxicologist is pharmacokinetic usage and overdose. It's clear to me someone doesn't understand overdose when they start talking about half-lives. And they'll ask me, well, how long is the patient going to be symptomatic? Well, I don't really know that. The only pharmacokinetic information that's really useful for me is Tmax or peak absorption. So when you look at LexiComp, Micromedics, all of that pharmacokinetic information about drug half-lives, peak absorption is done in healthy volunteers at therapeutic doses. They are not looking at overdose patients who are overwhelming all of their metabolism and elimination mechanisms. And so that's why if I know that a peak max of a drug is 4 hours, if I have a patient who's asymptomatic at 6 and it's immediate release, I'm okay saying, yeah, even they're not going to get toxic down the road. If they show symptoms, then it's admission, and I can't say, you can't use the 4 to 5 half-lives to say the drug's out of the system because you've overwhelmed everything. But quetiapine hits lots of receptors. It's a dopamine antagonist, a serotonin antagonist, a histamine antagonist, which is why we get the anticholinergic effects. And then it causes peripheral alpha receptor blockade. The other thing is I'm a huge fan of push dose pressors, excuse me. This is an overdose. If you have a hypotensive patient, you should not be using epinephrine. It's actually going to worsen the hypotension.
Internet might have blipped.
I was just going to ask if
That's
it was
what
just
I
me
was
or...
guessing.
Yeah, okay. The wind, you're right, Stormy.
I just sent Heather a text message. We have a pretty bad storm here in Twin, so I wonder if something happened to her internet. So I'll hopefully hear back from her in a second.
Thanks for contacting her.
Yeah.
Oh, sure. Yeah. Heather's, there's always these twists and turns. Like you don't know about some of this stuff until she tells you. So it shows how much, oh, she lost power. Oh, darn.
Oh, shoot.
Oh, no.
Okay.
What's happening over there?
I think
in
Dr.
Twin?
Burris
What
can
kind of
take
storm
over.
you got?
Oh, yeah, I can try to help.
You've got this.
Well, like I say, I just learned something new like 2 seconds ago. Don't give epi to this person. Seroquel overdose. Oh, she's back. Yay.
Okay, sorry. We just lost power at my house, which means I lost internet, but I think we're good.
Oh no.
Heather, you had me panicked because I don't know the answer to why we can't give epi. I didn't know that till now either.
You're good. We'll find out in just a moment. But yes, avoid epinephrine. So the next slide. So pharmacokinetics of quetiapine, it's rapidly absorbed. It has no features that make it amenable to being dialyzed off. So it is a large volume of distribution. For drugs that are highly dialyzable, you want a small volume of distribution. It's lipid soluble. Drugs that we can dialyze off are water soluble, and then it's highly protein bound. So none of those things make it amenable to removal by extracorporeal means. The next slide. So is everyone familiar where we have alpha receptors and beta receptors? So we have alpha-1 receptors on our peripheral vasculature, and this is the blockade that we see with Seroquel. We have alpha-2 in the CNS. We have beta-1 on the heart, and then we have beta-2 on the vasculature. There are other places, but that's the big thing. So if you have a Seroquel patient who's overdosed, they blocked their alpha receptors, and so now they're not vasoconstricted, they're vasodilated. And then you throw epi on, which is non-discriminate, and it causes beta-2 activation, which then promotes more vasodilation. So there's some general principles in toxicology. If you see a wide rhythm in a young patient who's overdosed, before you think non-sustained VTAC, throw some sodium bicarb at them because it may just be sodium channel blockade causing QRS prolongation. If you have a cardiac arrhythmia that you would normally give amiodarone to, in a tox patient, we go for lidocaine. If you have one pressor to use, it's Levophed. If you have a tox-induced seizure, it's benzos, more benzos, propofol if their pressures will tolerate and you're intubating them. Lots of good evidence on phenobarbital, more emerging evidence on Keppra. But we never use phenytoin because it actually has cardiac effects. It also causes sodium channel blockade. So that is never the right answer in a toxin-induced seizure. So how do we manage Seroquel overdoses? CNS depression, you have to ascertain whether or not you need definitive airway management. I think the back slide. Perfect, thank you. For me, I will often give physostigmine if I have a moment. Hypotension, first IV fluids, then Levophed. Again, avoid epinephrine for the mechanistic reasons that we just discussed. And then seizures in the pre-hospital setting, benzos, more benzos. So now we're going to move into what probably was what most of you were hoping to learn more about, and which is really in some ways a minority of the talk, but it's sedation in the critically ill tox patient. So actually there is good evidence for antipsychotics, particularly in patients with sympathomimetic toxicity, for example, methamphetamine. So this first randomized controlled trial was actually in 1997. I was still in high school. So, you know, it shows you that there's not a lot of good, high quality data coming in the tox world, but they found droperidol was more effective than Ativan in patients with agitation due to methamphetamine intoxication. It was associated with more rapid and profound sedation with a decreased need for repeated dosing. Another study looked at it and they gave 10 milligrams of IM droperidol for patients who were acutely symptomatic with methamphetamine toxicity. They had to repeat that dose in about 20% of patients, and the peak plasma concentration for droperidol was observed in about 10 minutes. And that's the dose I use. So I use 5 milligrams IV and 10 milligrams IM for agitation and delirium requiring pharmacologic management. As I mentioned earlier, olanzapine is another option. You're not going to have that most likely in the pre-hospital setting. For ER physicians, you have to be aware there is this FDA warning that they shouldn't receive IV benzodiazepines if you've given IV olanzapine within an hour due to a risk for increased sedation. It's still done, and there are organizations that say it can be done safely. It's just being cognizant of the fact that they can have hypotension, CNS depression. And mechanistically, antipsychotics make sense in this patient population because there's an increase in brain dopamine levels associated with sympathomimetic toxicity. Next slide. So butyrophenones are first-generation antipsychotics. So this is droperidol, Haldol. Obviously, as we talked about earlier, the big fear is the risk for torsades and QTC prolongation. And here's what I'll say. We really don't care about QTC prolongation in and of itself, right? Yes, the reason that there's all this hype is because of the risk of torsades. It's actually quite rare. If you look at the studies that gave droperidol a bad name, I mean, they're 600 milligrams, huge doses. And that doesn't mean you can't see effects with smaller doses, but for the most part, when they were talking about how dangerous this drug was, it was with massive doses that you just don't see in clinical practice. And it was used for years before it got that warning. There may have been some political effects with Zofran being marketed at about the time that it got the black box warning. And Zofran causes QT prolongation as well. Obviously, the EPS side effects that Berta spoke to earlier, specifically dystonic reactions and akathisia. Akathisia is the big one. And I see it every shift because I use a lot of it. Sedation and hypotension. And obviously, sedation is the intended effect when you're using it to control agitation in some of these patient populations. Next, benzos. I feel like it's really hard to go wrong with benzos for any toxicologist. There's various options. Right now, there's been tons of drug shortages, both with narcotics as well as benzodiazepines. So I feel like every shift I'm changing what I do, but I use big doses. So if I have a patient who's psychotic and agitated with LSD, I'm usually starting, and they're an adult, 4 milligrams of IV Ativan, and I'll back it up. There's evidence that other benzos are better options because of the risk for dose stacking associated with lorazepam. So midazolam and diazepam have faster onset. So you can give the medicine, you're like, I'm not seeing the effect, back it up. The problem with Ativan is because of the delayed effect, you might prematurely be giving more doses, and then you have this lag, and then the patient's completely obtunded. So there is that thought. I would say that most people probably underdose their diazepam. When I'm working with an agitated patient, I'm starting like with 10 to 20 milligrams of IV diazepam. I never really give less than 5 of midazolam if I'm dealing with an acutely agitated patient who is overdosed. So that just, the next slide just gives you some comparison of the available benzodiazepines. Next slide. So what are some of the benefits? Well, obviously it's first line treatment for seizures in general, and obviously tox-induced seizures. It can be really helpful in patients who have muscle rigidity associated with their overdose, so severe serotonin syndrome. In addition to a benzo, an antipsychotic may accelerate the CNS depression that you're hoping to achieve. There's studies that show that 5 milligrams of IV droperidol plus 5 milligrams of IV midazolam is superior to 10 milligrams of IV droperidol or 10 milligrams of IV olanzapine alone. I will say anytime you start mixing medications, I think you also see more side effects. It's less predictable. And then, as we talked about earlier, midazolam and diazepam are associated with the fastest onset, which helps us to avoid dose stacking. The next slide, dexmedetomidine, which is Precedex. We don't use it a lot in ER medicine. I would say ICU docs use it a lot. I would guess sometimes you guys are using it with transport, although probably not starting it in the field. Is that correct?
Correct.
That is correct.
Yes.
Okay. So this is something new since I trained in terms of its use in toxicology. It is not helpful for rapid management of a psychotic patient. But there is some evidence that if you've had to control behaviors and you're worried that as the drugs given to initially control the psychosis and the delirium wear off, that you're going to have increased agitation, that you can start a high dose infusion, and usually it takes about an hour to see those effects, but then the patient is more relaxed. There is some, I would say, expanding literature to support the use of dexmedetomidine in severe serotonin syndrome patients. So these are patients that are in the ICU. So I have started using this in my intubated serotonin syndrome patients. I do not believe in cyproheptadine. I don't think it does anything. So I think this has some value. Next slide. It is a sympatholytic, sedative, and analgesic. It does not affect respiration. Again, the evidence to support its use is scant, but there are some case reports and emerging support in the tox community to use it for severe serotonin syndrome. Again, it's not going to be useful for that immediate, I need to control these things over minutes. We use the higher infusion rates, and then it has this gradual effect. The most common side effects that we see are bradycardia and hypotension. Next slide. The reason that it has some benefit, both theoretically and mechanistically in serotonin patients, is because it stimulates alpha-2 receptors, which again are in the CNS, to inhibit the release of serotonin. So you decrease those serotonin levels and basically calms that autonomic hyperactivity that is such a, key feature of serotonergic toxicity, and then it promotes sedation. And here's the drug that I feel like every EMS provider loves, ketamine, right? And I think it's a good drug. So I think it's a good drug with the right patient population. It would not be my first line, except in certain instances of, hyperactive delirium where the safety of the patient and the provider is paramount and we need rapid control of the situation. And I think those are challenging situations. Obviously, there's a lot of press currently regarding the case in Colorado. There's another case I don't know if you're familiar with in Utah about a patient who got intended to get pain medication dosing of ketamine, got 500 milligrams. Somehow, I don't think that was initially relayed to the hospital. I'm sure there was a drug error, ultimately died. It sounds like that's currently in litigation. But in my opinion, all drugs given at wrong doses can have deleterious effects, right? All drugs given at therapeutic doses can have deleterious effects. So I think the key is if you're giving a drug, you need to be cognizant of what can happen and prepared to intervene if needed. As I mentioned, so another toxicologist that I trained with, Dr. Andrews, brilliant. He does tons of medical legal work, probably the smartest man I've ever met. And he does not like ketamine at all. And I disagree. I think there is a point in time where it's appropriate. I don't think giving high doses of IM Versed to an acutely agitated patient is without risk either. I mean, you have a patient who's got a profound metabolic acidosis, who's agitated, delirious. So then you suppress their respiratory drive and then you worsen the metabolic acidosis and then they arrest. I mean, I just don't think you have a great option. It's a challenging situation. So you do the best you can in the moment. And I think you be prepared to deal with the consequences. So next slide. Okay. So again, I think it's appropriate with extreme violence and agitation. It promotes immediate sedation. We know physiologically it increases blood pressure and heart rate. And that's one of his big qualms, is these folks are already like tachycardic, tachypnic, hypertensive, and then I'm giving a drug that promotes more of that. So the argument is, if you can rapidly de-escalate, then you're going to counter some of these effects, because some of that is obviously exacerbated by their agitation. I would argue that you need to closely monitor their vital signs. Some of the advantages: it has hemodynamic stability, it doesn't suppress respiration usually. And again, usually, I have had to intubate patients who've had IM ketamine given in the field. So at large doses. And then there is an anti-epileptic effect. So hypertension is one of the things you need to watch for in these patients. Hypersalivation, especially if they get obtunded. Theoretically, it shouldn't affect their airway reflexes, so you're less concerned about aspiration in patients who you're going to be starting on BiPAP. And I don't really feel like there's a role for BiPAP in tox patients, right? If they're obtunded and you're doing BiPAP, it's not temporizing. They just need to be intubated. But that is the one caveat they talk about. It does have psychomimetic effects. So I think that's one thing potentially that people who work in the pre-hospital setting don't see, right? Like, you give Granny a pain dose of ketamine for her hip fracture, and then you leave and I get to deal with her like emergence phenomenon. And theoretically, they're like, it's subdissociative, and so you shouldn't necessarily see those emergent effects. I've seen them. I think enough of us who've worked in the ER, you see them. And that's not a contraindication, but it is just something to be aware of. I actually don't even use subdissociative dosing for abscess drainage in patients who have like a really big psych history or PTSD, because they usually go on bad trips, even at those lower doses. We do see nausea and vomiting, and then laryngospasm, which is more common in pediatric patients. I use a lot of ketamine for pediatric sedation. It was my first year out. I was doing my fellowship. I was working in a small ER, and I had a kiddo who needed a procedure. She had a big tongue lac. And so I used ketamine and she did laryngospasm. It's the only time I've had it happen. It was pretty frightening. You know, you have a 6-year-old child who's laryngospasming, you're bagging her, you have 2 very concerned parents. But when I look at all the doses given, it's a very low incidence, and again, more common in pediatric patients than adults. And then intubation, obviously, always an option. I am a fan of etomidate for tox patients. Recently, I consulted on a patient being seen in the Wood River ER. He was a Wellbutrin overdose in like a 17-year-old. He was highly, highly tachycardic. It's a nasty drug. Lots of times now we're actually getting them, especially pediatric patients, to facilities with ECMO capabilities, which is primary children's in this region, in the event that they decompensate. That ICU attending wanted ketamine as the induction agent. That would not be my first choice. But again, you're going to have different opinions from different providers. And I'm not naive to the fact that you're not going to make all of us happy. But consideration, obviously, with refractory agitation, hyperthermia, logistics, like, do we need to do additional testing like CT scans to rule out trauma? Propofol may be a good option at appropriate doses. Even propofol has issues, right? There's something called propofol infusion syndrome, which can be deadly and is problematic. And sometimes the patient's pressures won't tolerate it. I would say that's most commonly why I have to discontinue it, is because of hypotension. And then obviously we want to avoid physical restraints if we're able to, just because that worsens the observed metabolic acidosis and potential for death and significant morbidity. And that's it. Any questions?
Dr. Bean.
Yeah, Heather, another question. We actually were talking about our ketamine dosing for our folks that are agitated that we need to give IM and IV doses to.
Mm-hmm.
We were talking between 3 to 5 milligrams per kilogram, but the literature I've seen shows that 5 milligrams per kilogram often ends up in respiratory failure and requires intubation. So do you have a good amount that you suggest starting both in the IM route and the IV route, so we're not having a bunch of iatrogenic intubations?
Yeah, so I do 1 to 2 IV, 1 to 2 milligrams per kilogram IV, and then I'm 4 to 5 with the IM, 4 to 5 mg per kg IM. But I agree with you. Like the 5 mg per kg IM, it's about 50-50 when I've had to intubate following it. And I'll be honest, I fortunately don't usually have to give that dose, right? That's usually what they've gotten in the pre-hospital setting. And so then I'm seeing them, and then due to airway compromise, I'm intubating them. But yeah, I probably lean closer towards the 4. But the question too is like how psychotic and agitated and aggressive is that patient? Because if the question is like, I'm going to give 3 milligrams IM, but that's not going to adequately control them, and then I'm going to have to do it again, is that the right answer? Or do you say, I'm just going to give a bigger dose to begin with and be prepared to intubate? I don't know.
No, that makes some sense too. So and most of these are going to get IM because if they're that agitated, you're probably not going to get an IV in them.
Yeah, so I would say, in that, how often do you guys have to do that? I don't do anything really with the pre-hospital providers other than getting their report. So I don't see, like, you guys probably have an idea, how many times are you giving, that dose of IM ketamine for psychosis and agitation? Do you have that information?
Yeah. We do. We could pull the cases, but it's infrequent. At least it's generally MVP that has to do that, just because they're the ones more likely to do pre-hospital. But it's a minority of cases, probably less than 10 a year.
Okay. So I think as
but
long as that's the case, right? Because I would say if you're seeing this big trend, that's a problem, right? Like to me, that means that it's being overused. But if it's like 10 cases a year, then I think you also have to say, is the risk of respiratory failure, which isn't guaranteed, but is potentially going to be the outcome. I would say that may be a better option than them having to have repeated doses of IM to control them. That's my take.
All right, thank
Excellent.
you. That's actually helpful. And then we can just make a note that the higher doses, be prepared to intubate in our protocol, because we haven't protocolized that, but we're in the process of doing that. So that information is actually pretty helpful for us.
Yeah, and I think the other thing just to be cognizant of are these patients, like when you look at their labs, right, their lactic acid is sky high, they're acidemic. So being cognizant that sometimes I think we're really good at identifying like poor oxygenation and respiratory failure as reasons to perform definitive airway management. We're less savvy at understanding that, if I have a tachypnic patient who's agitated and aggressive, like, yes, some of that may be some pathomimetic effects, but another component is compensatory for the underlying metabolic acidosis. And if I sedate them and now they're breathing at a rate of 7, 8, that underlying acidosis may become worse and they could arrest, like also being willing to intervene if the respirations are inadequate, the ventilation, I should say.
Yeah, thank you, Heather. I guess one other thought I had listening to this lecture, which thank you, Heather, again for doing this, is this is like medicine, the more you learn, the less you know. Like there's so many things that we can do better on, and so it's if we're going to operate on that high level, we need to have consultants like Heather come in and tell us things like this. And that's how we get to that next level as a system. So I'm very appreciative of that. And like we're always trying to be better. So these are things that we can take and work with and probably save lives,
Well, and let me be clear, like I learn every time, right? The whole epinephrine thing in Seroquel came up like 4 months ago. And I was like, duh, I should have known this, right? like, but intuitively, like a case happens, you see something and then you learn. So I learn every day, right? And I think I'm more humbled now, 15 years into my career, than I was. I think an experience is a big confidence booster. Like once you see enough cases go south and you're like, I did everything right and by the book, it's humbling. And so this is never meant to be punitive, because I have made mistakes. I make mistakes every day, every week. But I try my very best to learn from those. And I think hopefully maybe you can learn from some of the mistakes I've made. And certainly, I think just understanding, again, if you come in and tell me you're starting a patient on ketamine for sedation and you have a rationale as to why you didn't use benzos, I do prefer benzos in most overdose patients. I think that's a well-known fact for me. But if you have a rationale other than I had the drug, then I'm okay with it. But you need to be able to explain to me why you deviated from what I would argue is standard of care or like first line treatment and went to something else.
Yeah, and I just one other point that you made that I just wanted to. I think this is something we've adapted at Magic Valley a little better, and maybe it needs to go out to the other teams. Is the etomidate for the induction agent, and some of those tox cases might be the better choice over the ketamine. You made that point, but that's something that I took from the lecture, and I think MVP's kind of adapted that over the years after talking with you.
No, and I will say MVP does a really good job, maybe because they're afraid they're going to have to report to me on an overdose patient if I'm working. I don't know, but they do really good. They are awesome about bringing in pill bottles. Like I've noticed this huge improvement from 10 years ago, right? Like they come in and there's bags like of drugs. And I just love it because it makes it so much easier for me to know what the patient had access to when that's an option. They do a really good job managing these patients. Like, yeah, all the way around. So kudos.
Sam, I see your hands up.
Yeah, Dr. Ellsworth, thank you for this. This is incredible, as always. I have a couple
I don't
questions.
think I deserve that, Sam, but thank you.
Well, no, it always is, and so I appreciate it. Couple questions. I was seeing if we could, I know we only have a couple minutes left, of like the medication cabinet murder type style, or like topic of, salicylates and things that they're found hidden in, like Pepto-Bismol, things like that. Can we lean into that a little bit? And then I was seeing if you had any thoughts on the high school kids and mixing their new version of purple drink called Lean, and anything with the kratom and their treatment with ibogaine. I had a gentleman that had an NSTEMI coming back from Mexico after ibogaine treatment. So any thoughts on any of that?
That's a lot. Okay, so with the salicylates, are you just asking like where are salicylates? Because you're right. So Pepto-Bismol has it, which oil of wintergreen is probably the most concentrated source of salicylates. Like most adults don't get into it, but I've seen like a long time ago pediatric exposure, and that's nasty. I guess, are you asking about management, or where can you find salicylates besides just aspirin?
Yeah, I guess it's more along the management. It seems like it kind of waxes and wanes in our, how often we see it, and if there's any changes in management, anything like that we should be aware of.
No changes in management, but every year, like poison control centers. So obviously, like we use Nebraska, the state of Idaho contracts with Nebraska. The University of Utah has a poison control center. I don't know how many there are anymore. There were a lot that got shut down due to budgetary constraints. But there's nothing that's really changed with salicylate management, but there are a few pearls. So when they look at over-the-counter medications causing deaths, salicylates is always at the top. And why is that? Because we mismanage it. Intubation, you should really, really be scared if you're intubating a salicylate patient. Like, and maybe not scared. You should be very prepared. I like that word, maybe better. So you should be prepared, and it's mostly because of the ventilation. So salicylates cause a mixed respiratory alkalosis, metabolic acidosis, And so they're huffing and puffing. Part of that's because of stimulation in the CNS by the salicylate, but part of that's compensatory. And so they have this profound acidosis. You go to intubate and then they arrest and they're dead. The other thing is there's like hard and fast rules about when these patients should be dialyzed. So an absolute level of 100 necessitates dialysis, but when you get to 80 and you're seeing issues, then they need to be transferred elsewhere. Obviously you're doing urinary alkalinization. And so you're starting these folks on, and it's urinary alkalinization as opposed to like TCAs where you're doing serum alkalinization because you're trying to get basically the drug off the receptors. Here you're trying to promote urinary excretion. And so you have to really alkalinize that urine. And so you're starting these patients on high dose bicarbonate fusions. And if you have them so they're hypokalemic, you can't adequately alkalinize the urine and excrete it. You also are at high risk for Bezors. So aspirins forms like these concretions in the stomach. They also induce pylospasm of the stomach. So they delay their own absorption. So there's all these caveats. I wouldn't say that there's anything that's changed, in the past probably 20 years or longer for management, but it's just that so often they do well that the really sick ones we mismanage because we don't understand all of those things. And in fact, like even aspirin, they can get a little loopy for a number of reasons, but it can actually lower the CNS concentration of dextrose. So if you do a finger stick on a bad salicylate overdose and you're like, boy, they just act wonky and it's normal, I still give them dextrose. Anyways, so there's that. I don't know if that really helped. Second question, sorry.
Anything with the new Purple Drink Lean, from what I understand, it is the 10% alcohol cough syrup that they get at the dollar store mixed with Sprite and Jolly Ranchers, and they drink a ton of it.
Yeah. So like the purple syrup was like dextromethorphan, robotripping. There's rappers that have rapped around it. I listen to old school rap, so I can't tell you about the newer ones, but they, there's nothing really to do other than support them through it, right? So if you go to Arrowhead, which is like an online forum for drug users to talk about their experiences, it's really helpful for toxicologists when a new drug is emerging because we don't have a lot of data, right? It's sort of like best guess. But really it's benzos. They try to get different plateaus. The problem and the challenge becomes once you start adding alcohol in, then you've just got a mixed presentation, right? So, you've got this, a couple things. You can see serotonin syndrome anytime you have dextromethorphan. And then you have CNS depression with the alcohol. So it's really supportive cares. There's not really a, magic antidote. And then your last one was on kratom.
Yeah, I know we've talked about kratom before and things like that, but I just never heard of this new, everybody's flying to Mexico to get ibogaine treatments for withdrawal symptoms. And I was just seeing if you had heard anything on that.
I haven't. We aren't using it here. Instead, we tend to use long benzo or phenobarb tapers.
Cool.
So.
Thank you. I appreciate that.
Okay.
Well, wonderful. Thanks so much.
You're welcome. If anyone has any specific questions, feel free. You can email me. I may not get back promptly. I'm going to be working nights, but I can get back when I'm off. And then I'll look into that question you had, Bertus, about differences in akathisia associated with the droperidol dosing, see if there's an answer that I can find.
Awesome.
Okay. Thank you.
Thank you.
Great. Thank you so much.
Bye.
Bye.
Thank you.
Bye-bye. Thank you.
Thanks, guys. Have a good day.